So without wasting much time, we will go to the session. So the session will be like, first Dr. Haripriya will be presenting her case scenarios, followed by Dr. Harshith who will present his case scenarios. Then we will be having a question and answer session where the experts will answer your questions. I also request the participants and the guests and the delegates to put their questions in the chat box, which will all be answered in the question and answer session once the case presentation is over. So over to Dr. Haripriya. Can you present your case, please?
Yeah. Good evening, one and all. As Dr. Surendran said, today's session will be on iris and uncertainties. At the outset, I would like to thank MCure for giving me this opportunity to share my views and on this important topic of iris and uncertainties. As Dr. Surendran rightly mentioned, we have very difficult in diagnosing and treating this condition. Most of us have been familiar with treatment options of opportunistic infections, and with the advent of new drugs and single pills, the HIV treatment per se has also become quite simple than compared to earlier. But we still have some challenges with uncertainties like this. One of them being the iris. Iris is immune reconstruction in inflammatory syndrome. Basically, this is seen once the patient is put on appropriate ART, antiretroviral therapy in HIV patients. So we will discuss the definitions and how to deal about it as we go through. And first, I'll start the case scenario and we will go through it. Are my slides moving? Yeah. So this is the first case I have to present. This is a 42-year-old male who is doing a desk job at a private firm in Hyderabad. He presented with chief complaints of swelling in neck and cough, 6 months duration. Though he presented with swelling in the neck, that was not there when he says it comes and goes, so it was not there when during the time he presented. And also the other complaint is decreased food intake due to difficulty in swallowing of solids from past 3 months. So with this chief complaints, he presented to us. On further inquiry, he also said that there is a recent onset of low-grade evening rise of temperature of maximum temperatures of about 100.4 degree. There is no significant past history before the 6 months, other than the 6 months illness. So on examination, his oral cavity was normal. Though I couldn't make any swelling in the neck, there is some mild fullness in the right supraclavicular region, but on palpation, couldn't feel any lymph nodes. And systemic examination was normal. He has these investigations by the time he presented, that is CBC. CBC was showing a hemoglobin of 10, total counts of 6,000, platelets of 250,000, lymphopenia with the total lymphocyte count of 850. By the time he presented to me, he was having his HIV report, which was done by the pulmonologist elsewhere. He presented to pulmonologist and then he was referred here because HIV was positive. So with this HIV report, he presented to us. So on further testing, I found the CD4 count were only absolute CD4 count was 40, and viral load was about 307,000. So VDRL was negative, HBsAg and HCV were negative, serum cryptococcal antigen was also negative. So in all cases with the CD4 count less than 100, we do a serum cryptococcal antigen, and in this case it came to be negative. So as the imaging, he also has this imaging finding done by the pulmonologist. He is having the CT just showed findings of right supraclavicular conglomerate nodal mass. So there were supraclavicular nodes, but they were not like this individual nodes, and they were not palpable for examination. And imaging also showed there were multiple other mediastinal nodes and also bilateral small scattered lung nodules. they actually reported it as suggestive of metastatic process initially. And there was also a finding of asymmetric wall thickening of thoracic esophagus. So he was also having a difficulty of swallowing. The other main symptom was difficulty of swallowing. That was because of this inflammation going on in his esophagus. So this is his CT finding. This is the mediastinal window. These are lymph nodes here. Also the big mediastinal nodes, which, and also if you can notice, this is the esophagus, which is irregular, and this is also very at the upper level is just still small, very small esophagus lumen is seen, and this is also irregular. So with these findings already he presented to us. So at this stage, we have asked for to have a tissue diagnosis. We've asked for biopsy from the supraclavicular node. Our interventional radiologist team has done a FN5 needle biopsy, and the biopsy tissue was tested, and it came positive for the TB. So actually, it was stain also came positive for acid-fast bacilli, and gene expert was detected low, and rifampicin resistance not detected. Now we have the double trouble, HIV plus TB. So how do we go about it? What are the considerations at this stage? So when to start ART, and with this low CD4 count, with proven TB and widespread disease is there in a lung, it is likely like ameliorating in, it is there in scattered nodules in the lung, mediastinal nodes are present, supraclavicular nodes are present, and his CD4 counts are as low as 40. So the considerations here are, if we, of course, we immediately start ATT, the four drug regimen. Before that, we have sent the samples for histopathology and also for AFB cultures. So with the preliminary diagnosis of no rifampicin resistance on gene expert and AFB TB detected, we started him on he started on his weight-based 4-drug regimen, HRZD, and with his CD4 count of 40, he was started on PCP and Mycobacterium avium complex prophylaxis because his CD4 counts are very low. And at 2 weeks, he was reviewed. After he was doing fairly well with the ATT, and he came back for review, and it was planned that we start ART after 2 weeks after ATT. This is the recommendation when there is when the CD4 counts are less than 50 to start your ART as early as possible within 2 weeks. So we have reviewed him at 2 weeks. He seemed to be like settling from his fevers, and he a kind of stable, and so we started him on TLD with double dose dolutegravir regimen. So because of rifampicin has interactions with dolutegravir, it requires higher dose, and with this we kept him under close observation. And 12 days after starting ART, he presented to OPD and with low-grade fevers, minimal increase in right supraclavicular node swelling. So a small dose of NSAID was prescribed, and he was reassured because it is very minimal symptoms and very minimal increase in the, that is what he was complaining, but as such, there was no increase in node swelling apparently. So 4 days later, he presented to ER with complaints of severe retrosternal pain, fever, and significant increase in size of neck swelling. This is not 4 days later. The picture you are seeing is his right supraclavicular node, but that is even much later after this 4 days presentation. It was grown so out of proportion, and you can see the inflamed skin over that. So we've asked for, also he was complaining some pain in retrosternal region. So we repeated chest imaging. It showed persistent mediastinal adenopathy and esophageal wall thickening, and also there was some suspicion of nodal perforation and communication. So we have asked for, and he was also complaining retrosternal pain. So we have asked for our medical gastro team to have a look. They have gone through the images and they said there could be some tracheoesophageal fistula. They have posted him for upper GI endoscopy, and as they suspected, the upper GI endoscopy revealed tracheoesophageal fistula. Biopsies from the ulcer were taken to see if there's any other opportunistic infection or it is only because of TB what is happening. So we have they've shown the biopsy ulcer gene expert was also positive, and there was granulomas in histopathology. The prior his histopathology report also showed necrotic granulomas, and by this time he was 2 weeks elapsed, and we also had his tissue AFB culture report from the initial sample that also showed AFB culture was positive, and we've asked for further drug susceptibility testing on the sample at this time. So at this stage, we are more or less sure that he was having a diagnosis of iris. So how do we define iris, and how are we sure that this patient has iris? So according to the as early as 2008, there was INSHI case definitions to use in resource limited settings. This was published in Lancet Infectious Diseases in 2008. So there are 3 components for diagnosing a paradoxical TB associated iris. So all the 3 components should be present. The first one being TB should be diagnosed before starting ART, which is true in our patient, and there should be initial response to tuberculosis treatment. This is a little tough to establish in all the patients, because in 2 weeks, maybe patients might not show all improvement with TB medicine also. The second thing is clinical criteria. It should be within 3 months of ART, and any new onset, new or enlarging prior, any new symptoms or any increase in the previous symptoms, or any worsening of imaging findings, any new or worsening of old new CNS TB, or if it is in prior CNS TB, any worsening of it, or a new or worsening serositis. These are all the major criteria, and minor also few symptoms like fever, cough, dyspnea, or worsening abdominal pain. These are considered as minor criteria. So this our particular patient, if you notice, he had his TB diagnosis was made before starting ART, and there was some stability in his clinical condition after ART was started. And coming to the clinical criteria, he definitely had a significant increase in the prior lymph nodes, and also there is worsening in form of developing a new tracheoesophageal fistula, worsening. There is some nodal rupture at tracheoesophageal fistula. So based on these two, these 2 criteria are so fulfilled. Then the important thing is exclude other possibilities. Failure of tuberculosis treatment because of drug resistance. In our case, at least from the expert, we are sure that it is not rifampicin resistant, and the patient was fairly adherent to his tuberculosis therapy. The other diagnostic clues, as our histopathology, both the histopathology of the earlier node also came back. There was no other suspicion of other infection or neoplasm at this stage, and he was microbiologically also it is confirmed as AFB also grew, and it was expert positive at first place. So in certain conditions where the diagnosis is not microbiologically proven, like maybe clinical suspicion, if they start on a TB treatment, there could be TB. At that time, we have to see whenever possible to establish microbiological diagnosis. There is no suspicion of drug toxicity or reaction in our patient. So going by this criteria of paradoxical TB, our patient fits into this, and so we have made a diagnosis of paradoxical TB associated iris in our HIV patient. So what are the treatment options? Okay, so basically, this is the same what I've mentioned. There is also another type of TB iris associated with HIV. Suppose if the patient didn't have a diagnosis of ART, if he's TB before starting ART, he had only occult or some subclinical TB, which was missed because he was not having symptoms of fever or no suspicion clinically, but still there is some subclinical TB. Once ART started, it is likely that immune reconstruction happened and unmasking TB appears. Then this is called unmasking TB iris. So both form, if it is just an unmasking TB iris, we can start appropriate therapy for the opportunic infection, that is TB in this case, and assess for the treatment, assess for the response. So briefly, a word about pathophysiology of this iris. Basically, if you see in this, so when there are CD4 count, CD4 cells, this top column shows how it curtails the infection. So these are resting macrophage cells. When there is a TB infection, the CD4 cells activate infected macrophage. Fully activate infected macrophages. So once the macrophage is infected by the TB cell, the CD4 cells activate it and causes a release of these cytokines and bacterial containment. So it controls the disease. But when there are no CD4 cells, these are macrophages are infected by bacteria, but they are not primed by the CD4 cells. Once the ART is received, CD4 cells come back. So because of this accumulation of primed macrophages waiting for T cells, once the CD4 cells are in place, there is high levels of cytokine release. There's interferons, TNF, and IL-6 and others. There's excessive inflammation and tissue destruction. This causes iris. So this is in short, the pathophysiology of iris. The picture on the left shows a balance between subsets of CD4 T cells, helper 1 cells and helper 2 cells. The T helper Th1 or the T helper 1 cells, which are actively involved in the phase in the process which I described. When those cells are less, the other cells are more, and there is no balance. If we start a fungal or antibacterial therapy, that is ATT in this case, and wait, the balance settles, and once we introduce ART, then there will not be a high chance of this inflammation. If in otherwise, when there is an imbalance and when ART introduced, the balance tilts, and then we have iris. So what are the treatment options we have? This treatment options we have are for minor cases, we can go with the NSAIDs. If the symptoms are severe, we might be needing corticosteroids, and the dosing for the treatment being 1.5 milligrams, and other agents like biologics like thalidomide, other TNF alpha inhibitors have been seen in refractory cases and in some case reports. So this is a PREDA trial which shows the significance of starting steroid along with ART in patients who are recently started on ATT. So this study, they've enrolled patients who are ART naive and who are initiated on TB treatment in the last 30 days, and they have randomized 2 patients giving ART along with 40 mg per day dose of prednisolone and ART alone. So the tuberculosis iris was more in the patients with who didn't receive prednisolone. So the recommendation from PREDA trial was prednisolone treatment during the first 4 weeks of initiation of ART in patients who have CD4 count of less than 100 and who are recently started on ATT. So coming to the second case, this is one tough case we had by diagnostically also, because patient had very limited resources. We'll go through this case. This is a 52-year-old male from Maharashtra who had complaints of fever, vomiting, and cough. Initially, vomiting was little, but 6 months back. For these complaints, he was evaluated elsewhere. His sputum was expert MTB negative, but they did a chest imaging, CT chest, which showed fibronodular lesions. They somewhere they have started on empiric ATT. Fever and cough decreased, but however, he had severe gastritis and intolerance to ATT. So he stopped his ATT after 1.5 months, and he sought some alternative medicine help and for TB apparently, which details were not available. He then had continues to have weight loss and appetite loss. He before presenting to us, he presented elsewhere with a new onset of severe headache and vomiting. There they have done bronchoscopy because previously he was he was taking ATT and he stopped. So bronchoscopy was done elsewhere, and from there he was shifted to our center. He came with BAL report showing expert MTP detected very low and RIF resistance not detected. HIV-1 was positive. His CD4 count was 28, VDRL negative, and his serum cryptococcal antigen came positive. At this stage, clinically, he was having from history and also from the examination, his clinical diagnosis was more or less sure of meningitis because he had a new onset of severe headache and his refractal vomitings are going on. So we asked for an imaging to see for meningitis, but only MRI brain plane was done for reasons not known. Contrast MRI was not done, but a plain MRI was done and it showed no space occupying lesions. And the further plan was to do an LP to see the number of cells, to see the cryptococcal antigen in, and also asking for cultures to see if there is cryptococcal meningitis or it is TB meningitis that we are suspecting. But patient did not agree for LP, and he was asking for discharge against medical advice. At this point of time, we were not sure what to advise him, and family was upset, and they were not having finances. They were asking for some sort of therapy. They were like, we don't have any resources, what we can do. So we are stuck what to treat. TB meningitis, cryptococcal meningitis, we have no idea. We can't exclude either. Clinically, there is some evidence of both infections, and we don't know what is causing meningitis unless we have a LP. And then also the other challenge is when to start ART with so low CD4 count of 28. His risk of ART, HIV related mortality is very high, and is having two opportunistic infections, probably with probably with meningitis. So we are stuck at this point. So we decided to restart his ATT and also treat for cryptococcal meningitis at this point. And we started on liposomal amphotericin and fluconazole. And so the ATT, sorry, we also started ATT. And the question is when to start ART. We asked him to come back after 4 weeks to start on ART because we want to take time, because cryptococcal meningitis and TB meningitis are something we need to be more vigilant, and starting ART we should be little conscious, because the chances of CNS iris are more, and if CNS iris happens, it is tough to deal and symptomatically. So we plan to defer his ART at least a minimum of 4 weeks, and ask the patient to come back after 4 weeks because he wanted to go back to hometown for treatment of OS, and then he actually came back for follow-up, and he was started after 2 weeks of he took 2 weeks of amphotericin B IV as advised, and also fluconazole, and then he came back after 4 weeks. He was doing well, and we started ART after 4 weeks. We started actually at 5 weeks. So what is the rationale, and when do we start ART in cryptococcal meningitis? So basically, this is one study, code study, that is timing of cryptococcal, when to start ART in cryptococcal meningitis. So this this study included randomized patients to starting ART in 1 to 2 weeks of diagnosis versus differing for 5 weeks. So overall, the outcome they've seen is 26 weeks mortality. The mortality at 26 weeks was less in early ART. 26 weeks was more in early ART group, and mortality was less in a deferred group. And the mortality, whatever occurred, it occurred in excess mortality occurred in 2 to 5 weeks after diagnosis. So incidence of iris was less in the deferred ART group, but it was not significant. P-value was not significant in the study. So basically, there was mortality benefit when you start ART after 5 weeks. So in our patient, we started ART after 5 weeks, but patient did well. He didn't develop any iris, but in patients who start in whom there is iris develops, it usually occurs in as worsening of as new onset lesions, cryptococomas, or worsening of prior symptoms. So, or new imaging findings as I was describing for TB paradoxical iris, that also can happen. So if cryptococcal meningitis iris occurs, what is the treatment? When possible, it could be symptomatic treatment can happen. If there is raised intracranial pressure, therapeutic lumbar punctures can be done, or if there is hydrocephalus, shunting is an option. NSAIDs can be given for mild form of iris, but for severe and debilitating forms, we have to consider corticosteroids, particularly dexamethasone. Though there's one study which where they showed there is the inflammation with iris has come down, there was a significant mortality, higher mortality in those patients who received dexamethasone in cryptococcal meningitis iris. So the recommendations is when there is difference in opinions where treatment also. Whenever there is a cryptococcal meningitis iris in HIV patients, if manageable without steroids, if the symptoms are not severe, that is advised. And also advice is to continue ART and also to reintroduce the antifungals, liposomal amphotericin again if possible. If the symptoms are very severe and patient is not able to receive steroids for any reason, another option is what we have is biologicals, TNF alpha inhibitors, thalidomide. So we will hear more on that in coming session from Dr. Harshith. So these are the two cases which I had to present, highlighting importance of iris in TB and cryptococcal meningitis. We'll take questions at the end.
Thank you, Dr. Haripriya, for the wonderful case series of two cases. I mean, TB is quite common, followed by cryptococcus in HIV hosts, and we have seen two different case scenarios. And we'll move to the next speaker, Dr. Harshith. Over to Dr. Harshith. Once Dr. Harshith finishes, we'll take the questions. Thank you.
Thank you, Dr. Haripriya, and thank you, Dr. Surendran, for introducing me here. Quickly moving forward with the further case that I have to present now. That is, hello, are my slides visible?
Yes, go ahead, visible.
Yeah. So moving with the next case, I had a patient who is 35-year-old male who is MSM, resident of Hyderabad, economic writer by occupation. He had presented with complaints of fever, pain, abdomen, loose stools, weight loss, and for past 1 month, and he was admitted in February for this reason. At that time, he was diagnosed as a case of disseminated tuberculosis, similar to the case already presented by Dr. Haripriya. And his lymph node gene expert was positive for MTB, and rifampicin resistance was not detected. In the same admission, he was also diagnosed to be having retroviral disease with a CD4 count of 11. So eventually, he was started on weight-based antituberculous therapy, and 15 days later, giving a gap of 15 days, he was started on antiretroviral therapy with double dose DTG and TDF and 3TC, as also highlighted by Dr. Haripriya regarding double dose. So with this, his fevers had disappeared, and almost after a week, his fevers disappeared, and appetite has improved significantly. He was happy with this. Then 3 weeks later, he came again with high spike fever, sweating episodes, shortness of breath, abdomen distension, yellowish discoloration of eye, and painful defecation. On examination, he had tachycardia, and BP was borderline, and he had a lower saturation, which was again borderline, around 94% on crewmate. And further, he had icterus, and though no peripheral lymph nodes were palpable, he had some pedal edema. And on respiratory system examination, bilateral and inspiratory crepitations were audible in bilateral basal areas. And on abdomen examination, hepatosplenomegaly was present, and there was mild distension, slight tenderness also. No ascites was clinically palpable. And on genital examination, perianal ulcer was noted, which was erythematous base, superficial looking ulcer. However, no inguinal lymph nodes or any other ulcers noted. Cardiovascular system, except tachycardia, no other features were significant. In CNS findings, there was no neck rigidity or no focal deficits. So we investigated him and found out that he had bicytopenia and elevated bilirubin, liver enzymes were elevated, and inflammatory markers such as CRP, fibrinogen, ferritin, and they were elevated significantly, particularly with respect to ferritin and CRP. And procalcitonin was also positive, suggesting possibility of a sepsis with gram-negative organism in him. And looking further about possibilities of him before considering the iris possibility, and before starting on steroids, we wanted to rule out other possibilities. So we looked at viral hepatitis markers, and we did CMV viral load, and we did blood cultures, urine cultures, and serum galactomannan to rule out possibility of histoplasma here, as in our setting, histoplasma antigen was not available. And we did CD4 count to understand about iris part in him, and it was rise by almost 44 cells. It has increased. It was 11 before, and it has increased to 55 cells now. And also from the genital ulcer he had, perianal, we had a swab for looking at other STIs. HSV2 DNA was positive in him. However, gonococci and chlamydia trachomatis, nucleic acid amplification, were negative. And because of the bicytopenia he had, we did a bone marrow to rule out possibility of HLH in the presence of cytopenia and elevated ferritin and hepatosplenomegaly. That was just a reactive marrow as well. And we did ultrasound abdomen, which was suggestive of hepatomegaly with periportal edema, suggesting possibility of acute hepatitis. And there was periportal and peripancreatic lymphadenopathy, splenomegaly with multiple hypoic lesions. So in the background of already ongoing tuberculosis, without all the manifestation was because of multiple disseminated granulomas in spleen, and possibility of iris was considered. And we did a chest CT to understand about increasing oxygen demand in him or decreasing saturation. Towards the right is the panel where we had the CT which was done in January, his first admission. And to the left is the panel which was the recent one. There was increase in reticular opacicities as well as nodular opacities, suggesting increasing pulmonary infiltrates. So this suggested us of the possibility of paradoxical iris of disseminated TB with drug-induced liver injury because he had hepatitis and elevated liver enzymes as well. And also there was unmasking of CMV viremia, though he did not have disease. Fundus examination did not reveal any CMV retinitis, or there was no diarrhea at that point to suggest a colonic involvement. And perianal ulcer was because of HSV2. We could not do bronchoalveolar lavage or respiratory sample in him because of low platelet count and oxygen requirement at that point. So there was still suspicion of pneumocystis jirovecii pneumonia present. So he was managed with ganciclovir, 4-trimoxazole for therapeutic dose or for pneumocystis pneumonia, and broad spectrum antibiotics were initiated. And also acyclovir was given for genital ulcer along with doxycycline. And we added dexamethasone for the management of iris in him. So eventually his fever subsided, shortness of breath also resolved, oxygen saturation improved, and he was discharged home. Again, after 15 days of discharge, when he was in follow-up, his valganciclovir was discontinued because his CMV viral load was negative. Steroid dose were tapered. And he presents in OPD almost immediately after this, a reduction in steroid dose and stopping valganciclovir with fever and headache of 3 days. So now in a case of iris, TB, HIV coming again on steroids, coming again with fever and headache. So on examination, we found out that he had some skin lesions, which were erythematous, papillonodular, 5 in numbers over chest, shoulder, back, and left leg. There was no peripheral lymphadenopathy. There was persisting hepatosplenomegaly. There was no necrosality. So we were thinking about possibilities of his skin lesions as well as new onset fever and headache. So skin lesions, if you look at closely, they were erythematous, plaque to nodule kind of appearing with well-defined borders and raised surface as well. They were not tended by palpation. So differential diagnosis we considered for his erythematous papillonodular lesions were bacillary angiomatosis, AIDS-related Kaposi sarcoma, cutaneous pneumocystis, cryptococcosis rarely, or other possibilities such as histoplasmosis as well. For fever and headache, in a case already of iris coming after reduction of dose of steroids, first thing I was worried about was mostly worsening iris in him. Did we taper it too soon was the first thought. However, other possibilities needed to be considered in the background of this erythematous papillonodular lesions were Kaposi sarcoma with multicentric Castleman disease, Kaposi-related iris, CMV reactivation, and also we had to rule out meningitis due to tuberculosis or cryptococcosis. So we investigated further and we found out he had pancytopenia. This leukopenia was probably related to recent reception of valganciclovir. And his liver functions had returned back to normal baseline levels, but he had very high CRP levels at this point. CMV, we repeated again to understand the recurrence of that because he was on steroids, as we know. So that was undetectable. We thought possibility of EBV-related iris now that came very low copies, around 618, probably a bystander like. Serum cryptococcal antigen was negative. MRI drying was done, which was normal. CSF analysis was done, which had normal proteins and sugars and was negative for cryptococcal antigen origin expert. So we did a skin biopsy from one of the lesions on chest, and we found out that in dermis and subepidermis, we can see that there was vascular proliferation. And they also commented saying that they were lined by atypical endothelial cells, and it was negative for GMS or PAS stain, which ruled out the possibility of cryptococcosis or histoplasmosis, and even bacillary angiomatosis is found on Warthinstari stain and a PAS stain. So that was also a less likely possibility. They suggested this as a possibility of a vascular tumor in skin. So we further investigated to understand the possibility of lymphoma in him or other possibilities with Kaposi sarcoma. We did a PET CT, which suggested metabolically active lymph nodes above and below diaphragm. And as you can notice here, those lymph nodes were very prominently taking up FDG, particularly in periportal areas here and in the mediastinal areas, and also right supraclavicular area. And there was a significant uptake in his spleen as well. So there was also comment on miliary nodules in bilateral lung fields and lesions in spleen, as we have seen here. Miliary nodules which were there even in previous CT are still persisting. So diagnosis suggested by PET CT was active lymphoproliferative disorder with superadded granulomatous pathology in the background of an already diagnosed case of tuberculosis. So we did actually a biopsy from his right supraclavicular lymph node, which was easily accessible. But however, that turned out to be entirely necrotic, and we did not have any lymph node tissue for further evaluation. So we planned for next best possible approach for biopsy in him was endoscopic biopsy of his celiac trunk or para-aortic periportal lymph nodes, which were significantly having uptake. During upper G endoscopy, it was noted that he had erythematous lesions even in gastric mucosa, and there was also nodular lesion in gastric mucosa. So this again suspicion of skin lesions and these lesions correlated looked similar. So same diagnosis was suspected. We went ahead with biopsy from gastric mucosa, which was showing that lesion. It had significantly increased proliferation of capillaries in subepithelial space, and also there was noted of slit-like spaces in again in these capillaries. So this was suggesting of proliferation of small capillaries with slit-like spaces, and also nuclear atypia was suggested. So they again suspected this as a possibility of Kaposi sarcoma. So by this time, again, we had the skin biopsy report histopathology with immunohistochemistry, which was positive for HHV8 IHC marker. So again, confirming the diagnosis of Kaposi sarcoma in him. Also, other markers were looked at for possibility of vascular tumor. They were again suggesting of Kaposi sarcoma. So what is Kaposi sarcoma? This is a vascular tumor associated with human herpes virus 8, and hence it is also named as Kaposi sarcoma associated herpes virus. And it has 4 forms, which is AIDS related, endemic, which is seen in Africa, and organ transplant related, and also other is classic form of Kaposi sarcoma. And it is, with particular respect to our case, AIDS related Kaposi sarcoma, frequently it involves oral cavity, lower extremities, gastrointestinal tract, and respiratory system. And it is usually noticed after starting ART within 6 months mostly. And in those with low CD4 count, higher chances of Kaposi sarcoma is there. And recently, there is declining trend in Kaposi sarcoma with introduction of ART. So staging classification of Kaposi sarcoma, if we look at how this entity is very less known in our settings with very few number of cases with BC. So will this patient survive? Will this patient do good? Can we salvage him? Is Kaposi sarcoma a death sentence? All these questions were passing through. So when we looked at the classification for that, poor risk factors include those with extensive oral cavity lesions, gastrointestinal tract lesions, or other nodal, non-nodal visceral involvement, something like spleen or lung involvement. And also, if you look at immune status, those with low CD4 count are at poor risk. And in systemic symptoms, if somebody has other OIs, such as oral thrush or performance score is low, or HIV-related other lymphomas, they have poor state. So our patient had almost all of these patients. So why does HHV8 cause this? What is this human herpes virus 8? This is a double-stranded DNA virus, which is very similar to EBV, a cousin of EBV, we can say probably. And this is categorized as group 1 biological carcinogenic agent. This is one virus which causes, cancers. So this infects variety of cells, including endothelial cells, monocytes, and B cells. So thus it affecting these cells eventually turn into malignant cells when this enters into lytic phase. And it exhibits a latent and lytic phase similar to EBV. It can cause Kaposi sarcoma, primary effusion lymphoma, multicentric Castleman disease, and other inflammatory cytokine storm syndrome. This is a recent entity described. Yes. It is transmitted mostly by saliva, organ transplant, blood transfusion, sexual route, mostly not very proven about sexual route or how it is. Yeah. And mostly diagnosed with serology and PCR in blood and immunohistochemistry on histopathological slides. So further, in India, do we really have many cases? How is HHV8 in Indian scenario? Yes, it is less. More commonly, it is seen in sub-Saharan Africa, Mediterranean countries, but in US, Asia, and Europe, percent of seropositivity of HHV8 is less than 10%. In India, one of the studies documented it to be around 4%. However, point to note is that even in those countries with low seroprevalence, among MSM population, seroprevalence is pretty high, almost up to 20 to 60% in a study published in US. So this can cause multicentric Castleman disease, as we saw in our previous slide. What is multicentric Castleman disease? Does our patient have it? Because he has so much of lymph nodes, so much of splenic uptake. Yeah, let us see. So multicentric Castleman disease, it is angiofollicular lymph node hyperplasia. Usually Castleman disease is classified as unicentric, multicentric, among multicentric, whether HHV8 positive or negative. And histopathologically, it can have hyaline vascular variant, plasmacytic variant, or mixed histopathological findings. In immunodeficient patients, because of excessive replication of HHV8, uncontrolled replication of this, plasma blasts such as B cells, they start proliferating because these cells sit in plasmablast. This leads to release of cytokines such as interleukin 6 and interleukin 10. Particular point to note here is that this particular virus, HHV8, secretes a particle called as viral interleukin 6, which does not require any co-receptors, and it can go and directly activate vascular endothelial growth factors, and also it acts like human IL-6 as well, increasing all the inflammatory pathways downstream. So that is the reason why in most of these patients, we have multiple lymphadenopathy, including multiple regions, night sweats, weight loss, weakness, fatigue, which is a marker again, which is a signs of inflammation going on, hepatosplenomegaly, cytopenias, organ dysfunction, and skin fatigue. They're also related again to cytokine-related excessive release of these inflammatory cytokines. And these are again diagnosed with immunohistochemistry, where LANA, that is latency-associated nuclear antigen, will be positive. So typically, multicentric Castleman disease has a very typical picture on histopathology, which is called as plasmablastic histology, which is positive for HHV8, and it has interfollicular plasmacytosis, and follicle size keeps varying. They also call it as microlymphoma, kind of as another name for that. And there is increased vascularity, which is a very typical part of Kaposi-related diseases. And there is increased immunoblasts or plasmablasts. This is a representative image here presented, which shows larger cells, which are the plasmablasts, taken from internet source. So in our case, we did a lymph node biopsy from right supraclavicular lymph node, as I already mentioned, that turned out to be entirely necrotic. So why we did endoscopy was to go and get a lymph node sample from the abdomen. So in mucosa, already we had stomach mucosa, we already had a possibility of Kaposi sarcoma. We had done a antral biopsy from the celiac lymph nodes. In that, there was spindle cell proliferation was demonstrated, but there was no features of plasmablastic histology. So now what? Our case has so much features, very typical or very similar looking to multicentric Castleman disease, but not Castleman disease. Yes. So our case, we made the diagnosis at that point as disseminated TB, retroviral disease with AIDS, and iris, which was already diagnosed, and now he had Kaposi sarcoma with iris probably. So management for this is given by guidelines of National Comprehensive Cancer Network. We'll see in further few slides how they help us or suggest us to manage these cases. So what are the clinical presentations of Kaposi iris? It is usually first presentation or paradoxical worsening of pre-existing Kaposi infection following ERT initiation. In our situation, it was first presentation, and it typically occurs within 3 months of ERT initiation. Yes, it happened so in our case too. There is high risk if there is low baseline CD4 count and high viral load. In our case, we could not have a baseline viral load as it was diagnosed before he presented to us. And yeah, definitely he had low CD4 count with higher risk. And may develop new lesions. Yes, there was new onset lesions, which we noticed here. Worsening lymphadenopathy. He had lymphadenopathy before, but it persisted despite treatment of tuberculosis. Worsening edema. He had mild edema, but not really bothersome kind of. And diagnosis usually depends on exclusion of multicentric Castleman disease. Oh, so yes, our case is it again going towards more of Kaposi iris. So criteria for Kaposi iris given again by Cancer Network guidelines says that major criteria, at least one we should have, that is new onset or enlargement of Kaposi lesions. Yes, we had new lesions. And painful lesions. No, our patient did not have painful ones. Minor criteria include a decrease in plasma viral load. We could not document this because there was no baseline one available. And increased blood CD4 count after ERT. Yes, he had increased ERT, CD4 counts. So this fits more like Kaposi iris. Then what is Kaposi inflammatory cytokine syndrome? Is it same as iris? Is it any different? So inflammatory cytokine syndrome, as we saw, because of viral IL-6 as well as human IL-6, Patients present with clinical symptoms of fever, edema, neuropathy, gastrointestinal and respiratory symptoms. Our patient had similar of them. And they have elevated C-reactive protein. Yes, because of IL-6 stimulating it, there is significant elevation of CRP and hypoalbuminemia and thrombocytopenia. Yes, our patient had all of this. And they typically lack splenomegaly and widespread lymphadenopathy, unlike MCD. So this is a feature probably going against our case. So is it Kaposi inflammatory cytokine syndrome or is it iris? So it could be both. There is no way to disprove any of them in our situation. And if you look at prognosis of such situation, median survival is around 1 year only. So further, how do we manage this case? Management basically is through chemotherapy and supportive measures, again suggested by NCCN network. ART should not be discontinued despite however severe iris you think of. Thalidomide, an active agent against both Kaposi sarcoma and corticosteroid refractory iris, can be considered in this situation. And progressive disease, if it is there, we can modify chemotherapy probably. That is on the follow-up part. And it is best avoided, is corticosteroids should be avoided as much as possible because it may exacerbate Kaposi sarcoma. And systemic chemotherapy, if we start before ART, which is not an option in our situation, may prevent Kaposi iris. So this is the treatment suggested by network, where they suggest first-line therapy with liposomal doxorubicin, which is a toxic drug we already know about. And if it is organ transplant related, it should be sirolimus or other possibility of paclitaxel. On the right side, lower down here, if we can see, useful in certain situations that I mentioned about, etoposide, imatinib. In that, last one is thalidomide, which is for particularly suggesting for patients with iris. So why are corticosteroids causing such a harm? In a situation of iris, where it is life-threatening, corticosteroids are the lifesavers, but not in situations of Kaposi sarcoma. So there are studies evident enough, it is suggesting that it induces Kaposi sarcoma in those who does not have already. It increases the risk of Kaposi sarcoma iris. It exacerbates the existing Kaposi sarcoma and also increases the risk of death due to Kaposi sarcoma. These are the few studies which I have quoted here for that. So what about thalidomide? Do we have sufficient evidence? Thalidomide we already know for using for TB iris, particularly CNS related, and also in situations of corticosteroid refractory iris we use most often. And it is also a angiogenesis inhibiting compound. It blocks activation of nuclear factor kappa beta, which is again required for proliferation. And there are no prospective control trials to demonstrate its efficacy in Kaposi sarcoma, only some observational studies in which some partial response of up to 40% has been documented. And a cancer network suggests to start with a lower dose of around 200 milligrams per day. In studies, up to even 1000 mg per day has been studied for a median duration of almost 6. So how does thalidomide help even in iris situation? It switches from TH2 to TH1 response, which is a good response required. And in iris situations, and it helps in increased, in the sense, it helps in decreasing the levels of interferon gamma and TNF alpha. It inhibits particularly the production of TNF alpha. So thus it reduces the cytokines production leading to iris situation. So what happened in our case finally? We started him on liposomal doxorubicin. He received 2 doses already. He's due for third one on 2nd of June. Steroids were tapered in a rapid way. Now he is on 2 mg dexamethasone, and thalidomide was started at 200 mg per day. After 1 week of second chemotherapy, he started becoming afebrile. Till then, he had persistent fevers, and his skin lesions, which were very prominently observed in our first examination, they started flattening, and they started kind of peeling up from the above. And CRP was reduced from 190, which was at the diagnosis time, to 68, suggesting response to chemotherapy. And his appetite also has improved. So take-home points from my end would be, Early Kaposi sarcoma lesions may be mistaken for purpurous, hematomas, hemangiomas, dermatofibromas, or even NIV. Even when a single lesion is there, most often we tend to confuse them. And histopathological exclusion of multicentric Castleman disease is required for diagnosis of Kaposi inflammatory cytokine syndrome. Glucocorticoids are total no for Kaposi related lesions or malignancies. Thalidomide, a steroid sparing agent, is of significant help, particularly as it has even anti-Kaposi sarcoma effect. So with this, I conclude my presentation. We are open now for questions or any comments.
Thank you, Dr. Harshith, for this wonderful and extensively evaluated patient with Kaposi sarcoma, TB, and HIV. So we have few questions in the chat box already. I would like to tell them. So one is from Dr. Bishal Gupta. He has asked, for the first case, only cryptococcal antigen was positive in the serum and not in the CSF. So he wants to know, is the diagnosis of cryptococcal meningitis final? So how did you end up diagnosing cryptococcal meningitis?
We couldn't diagnose anything in him, so we chose to treat both. That is what I was telling during my presentation also. He clinically had a syndrome of meningitis, and he has evidence of both TB and cryptococcus, and we don't know what is causing meningitis, so we chose to treat both that, and that's what we end up doing.
Okay, so the next question from Dr. Anand Rao. So Dr. Anand Rao has asked, demonstration of increase in CD4 and decrease in viral load is essential for the diagnosis of an iris. So his question is, we always delay ART in the patients with HIV and TB if the CD4 is less than 50. So that's what his question is. What is the answer?
So for definitive diagnosis of iris, there are different definitions given. So what the definition I was referring to was proposed by INCHI and proposed in 2008 for resource limited settings. So that has about a sensitivity and specificity of about 80 and 90% respectively. So there are chances of missing, yes, diagnosis and also wrongly diagnosing, but that is for resource limited setting. And if we there are other definitions also by in which they as Harshith was telling in Kaposi sarcoma, the demonstrating 1 log value of viral load decrease and increasing in CD4 count by any amount. But also there are some definitions of demonstrating at least 20 increase in 25 cells of CD4 count. There are various definitions, but in resource limited setting, like suppose let us take our NACO program, we never document any baseline viral load. So it is not possible always to have plasma viral loads, and maybe repeating CD4 count when we have is an option in our setting. We can do that, but there are various definitions per se.
Yeah, as Dr. Harshith also mentioned in the second case, he has demonstrated rise in the viral load, but there was no baseline, rise in the CD4, but there was no baseline viral load in this patient. But a lot of other clinical indicators were there because the patient worsened after ART within 4 weeks, where you have tried to exclude other causes and extensively evaluated. So that takes us close to the diagnosis of iris. And he has also mentioned that when should ART be started in HIV TB if the CD4 is less than 50? I think my understanding goes, Dr. Harshith, you want to say something on that?
Sorry, when should we start about
ART in HIV TB when the CD4 is less than 50?
If you look at the Harrison description of such scenario, they usually suggest us to start simultaneously ART as well as ATT. But also, if you look at iris probabilities, when CD4 count is less than 50, chances of iris are very high. So it is a call whether how closely you can follow up a patient. If you're starting simultaneous ART as well as ATT is the thing that is a deciding factor, I believe. In our setting, we tend to wait for 1 or 2 weeks before initiating ART in a case with simultaneous TB and HIV.
Yes, even that is what the guidelines say, that if it is less than 50, we are moving close towards early initiation of ART within 2 weeks if we are not suspecting a CNS tuberculosis. So that is why we have started in both the patients, they have started ART after 2 weeks of diagnosis of TB. And there's another question from Dr. Kalyani. She has asked, do we need to wait till complete treatment of TB to start ART? I think we have discussed this. Actually, yeah, would you like to answer, Dr. Harshith?
Yeah.
Answer is no. Answer is a clear no. That is what we discussed. It is only 2 weeks we wait. And
if it is CNS TB,
it is CNS, even if it is CNS TB, the recommendation is about 4 to 6 weeks.
Okay. So there is another question. Is there any particular CD4 count or viral load criteria for diagnosing iris?
That is what
we have discussed that.
Yeah, regarding plasma viral load, it is 1 log copy reduction in viral load. But when it comes to CD4 count, only one of the criteria was by Dr. Robertson et al. In 2006, they mentioned about CD4 count increase by absolute numbers of around 25 should suggest, as a supportive evidence for iris. The
more important is the trend of the viral load and the CD4. We do not have absolute numbers to say and all those things. Okay, I think these are the questions from the audience. Like, I would like to ask 2 questions if I am allowed to ask.
Yes, please.
Go ahead.
So, Dr. Haripriya, your case, one with TB and cryptomeningitis is suspected. I would like to ask, for the audience sake, when you have a patient that you do serum cryptococcal antigen, if they don't have symptoms of meningitis, and if the serum cryptococcal antigen comes positive, that is asymptomatic serum CRAG antigenemia. So what do you do for those patients? When would you insist on an LP? Do we insist on an LP for all the patients, even without symptoms? So how do we go about that?
So the criteria for LP is like when the CD4 count is less, when the lesser the CD4 count, it is more likely. Usually we do when it is less than 50 or CD4 counts, and there is no particular this thing that, but for the treatment part, sorry, can you get any other question you asked? Sorry.
No. For asymptomatic HIV patient, it's HIV patient with asymptomatic cryptococcal antigenemia. They don't have symptoms of meningitis, like they don't have headache, they don't have vomiting. Your serum cryptococcal antigen is positive. CD4 is less than 100. So do we do LP in all those patients, or how do we treat that? Go about with that serum cryptococcal antigen.
Whenever possible, we if the CD4 counts are less than 100, whenever possible, we ask for an LP, even though there is no symptoms. But if there are symptoms, definitely we need to do. And if there is no CSF in blood in CS, there is no antigen in CSF, and it is only in blood, we can just go with only fluconazole therapy, high dose fluconazole therapy.
Yes.
800.
Yeah. So, and that case is quite complicated. It is easy to see on this presentation, but when you see a patient in real, you suspect TBM, you suspect cryptococcal meningitis. Would you give steroids for TBM? So you cannot give steroids for cryptococcal meningitis.
Yeah,
so
that is a very tough call. We didn't know absolutely. We didn't know which way to go. We were trying to balance both the TB, cryptococcus, iris, ART. It was very tough taking decisions, and we chose not to treat with steroids. And we didn't give him steroid because we didn't know what is causing TBM, and giving upfront steroids in cryptococcal meningitis can be harmful. We didn't have any definitive evidence of TB or cryptococcal meningitis.
Yeah, so furthermore, when we didn't do an LP, it is very difficult to diagnose. And there is another question: TPHA positive video or a negative in HIV should be treated or not?
Dr. Harshith, you want to take it?
Yeah. So usually, first screening test that we do in all settings would be VDRL probably, and a reverse algorithm would speak of TPHA. So to go about in situations, if there is definitive exposure for recent syphilis patient, then probably we should straight away go ahead and treat such cases. To know asymptomatic patients, to confirm it, probably we can repeat VDRL after a few weeks, or again we can reconfirm with other methods of TP, Treponema pallidum specific tests. We can consider in such situation.
Question from Dr. Ravi Bhushan. Dr. Harshith's case had more than 3 infections simultaneously. Is it possible?
Very much. In a patient who had CD4 count of 11, anything is possible. He's like a culture plate literally. So he had gram-negative sepsis, he had TB, he had HSP, all of that is possible. It's a real case. It's
Yes,
not a cover case.
yeah, it is a real case. It was a roller coaster ride. I was throughout the case where Harshith has daily some new issues coming up. He comes to me asking, Madam, today this happened. Today we have this again fever. Madam, could it be valgue and cyclic? Are we missing something? We had so tough time, and it is seriously patient had to go through all this. And yes, all the infections are for real.
And it's a wonderful learning experience through this case for all for us.
Yeah, a big kudos to you guys for having evaluated and treated that case successfully. So during severe iris, either ATT or ART should be on hold. Another question.
So if the patient is on both ATT and ART and he develops this paradoxical iris, there is no guideline to stop ART. Otherwise, the recommendation is actually otherwise you continue both. And if the symptoms are, if it is severe iris, maybe you can just go ahead and give one, as if guidelines is to give steroid dosing about 1.5 mg per kg of prednisolone and tapered over 4 to 6 weeks.
Okay, quickly moving on to the next question. Management of EBV viremia and HIV patients, because I think the participant has seen Dr. Harshith's slide. That patient had EBV. Did he have EBV viremia? So
Yes,
how significant is that, and how do we go about it?
EBV, see, when we have a diagnosis of iris, and if we rule out other possibilities, and it is just EBV viremia, usually with higher log copies of 5, 4, such high log copies, we consider EBV as the possibility for iris, and we treat it as iris. For particularly EBV, acyclovir is one of the options. And if we prove any lymphoproliferative disorder simultaneously in him, we can consider for rituximab therapy in such cases. Simple viremia of low viral copies probably is a bystander that need not to be treated.
One, I think it's the last question from the participant, from Dr. Chandani. She wants to know if in case of treatment in government hospitals, how important it is for patients to know the importance of both, I don't know what, I couldn't understand the question very well. So, yeah, so as closing questions, I would like to ask just 2 questions. How commonly do you practice this prophylactic prednisolone in your practice as per the PREDAT trial? Do you use in your patients?
After this case, I started using actually. It didn't come up. It didn't come up in any of our guidelines. There is this one trial, PREDAT trial, which is showing the benefit, but when we to start. But yes, after this case, in 2 other cases, I've started using because there is no mortality, there is no higher incidence of higher infections in the study, though it is not still given in any of our guidelines. I started using it personally over 2 patients whom I saw after this case.
Okay, so which patients do you choose for the prednisolone prophylaxis?
Strictly going by the PREDAT trial, those patients who are starting on
high risk for iris, basically.
High risk for iris, CD4 counts lesser, and one of my patients, I would like to, I was terrified. I've seen first time one patient has a CD4 count of 1. I don't know to start yet. I was tempted to start all of them at a time, like Harshith was mentioning as Harrison says, but I was still worried. I chose to start ATT first and then steroid and ART 1 week down the lane. So
Dr. Chandani has clarified that how important is it for patients to know the importance of both HIV and TB co-infection, because she believes that adherence to ART is more in HIV TB patients.
Yes, it is very much important to know, and our NACO program or even otherwise our NTEP program, which deals with TB and HIV programs, they make sure that a patient is diagnosed with TB, everybody has a check on HIV, and so for all HIV patients, they screen with the 4 symptoms, WHO 4 symptoms to look for TB, because as I mentioned, it is a double trouble and they have to be treated for both and under observation.
Okay, thank you. And this is the last question for the participants. Could you please share, when we see a HIV patient, can we predict that this patient might go in for iris? And what are the risk factors for iris, basically, is what I'm going to ask you. So
basically, the lower the CD4 count, higher is the risk of iris. The second thing, the more the disease burden, as I was explaining the pathophysiology, as it was more and macrophages are loaded, and then once the CD4 comes, so disseminated disease in short is higher risk of developing. And That's it. I could recall. Anything else you want to add, Harshith?
That, and also higher viral load copies.
Higher viral load.
Viral,
That's
yes.
one other.
Higher viral.
And regarding simultaneous initiation of steroids with ATT and HIV, I think as a general practice, it is not advisable where you cannot closely follow up a patient and where you don't have access for extensive investigation of possible OI if at all they come up again with. So it is a very tough and supervised call. It has to be, if I have to tell to the audience on that.
And how do you differentiate treatment failure and iris, which is the tough part? You do not know whether it is the treatment which is failing, for example, if it is an empiric ATT or an ATT.
Empiric ATT, it is a tough call because HIV patients are more, the drug resistance is more likely in HIV than non-HIV patients. And for this is why the empiric TB treatment should not be initiated. And even in government, we try to do CBNAT, which gives a basic information on rifampicin resistance. So we are more or less sure that we don't have drug resistant and failure. And other thing is absorption issues. Is the patient having GI issues? If we have to see, is the patient taking adherence is one thing. We have to check if the patient is failing on therapy, or if resistance is there or not, or drug absorption. These are resistance. I think we can only check, and also it is always advised to send all the samples for further investigations like LPA. There is a program management in which they send samples for CBNAT following LPA, following liquid cultures. Whenever possible, it is in spear positive patients and pulmonary, it is always advised to follow the protocol. And even in the non-pulmonary, extra-pulmonary, it is advised to have tissue diagnosis with minimum gene export or CBNAT.
Yeah. So
one small point to add to that. With the definition of iris itself is actually after ruling out all other possibilities.
Yes.
And also there has to be initial improvement in symptoms, which suggests that the treatment was working, and then the worsening.
Yeah,
So
that is sometimes may not be possible in the scenarios which we were talking. Yeah.
So yeah.
So a big thanks to Dr. Haripriya, Dr. Harshith, and Emcure for making our Saturday evening very productive for this 1 hour. I think we'll break for now. And so yeah, in the era of instis are very potent drugs, and there is rapid reduction in the viral load with instis, so which is also a risk factor for development of iris. And so I think now everybody will, when we see a HIV patient, we will keep iris in mind when we follow up the patient or when we start treating those patients. And it was very productive to discuss all these cases. And thanks for this case of Kaposi sarcoma. In fact, that is the first case real case which I am seeing in this presentation. So thanks for this opportunity. Thanks to all the participants who have joined us and who have listened to us patiently for this discussion. Thank you.
Thank you so much, Dr. Surendran, and also thank you, MQR, for giving us this opportunity on this discussion.
Yeah.
Thank you, Dr. Harshith, Dr. Haripriya, and Dr. Surendran.
Okay.
Thank you all delegates.
Happy.
We are ending.
Yeah.